When does heartburn become something more serious like GERD?
Heartburn, GERD, reflux, indigestion, it's really all one and the same. They're synonyms for the same disease. It becomes more severe when the patient's symptoms become more severe, when they have complications from it, like a scarring or a stricture in the esophagus, or Barrett's, which can be a precancerous lesion, or when the medications just get where they're not effective for them anymore and they seek other treatment options.
And what typically causes reflux, and how do you go about diagnosing it?
It's a mechanical problem. We all have what's called a lower esophageal sphincter. The lower 4 centimeters of the esophagus is a high pressure zone which keeps acid from going back up into the esophagus. There's also anatomy between the diaphragm, the esophagus, and stomach, certain angles. And when you have a hiatal hernia, those get disrupted, make the valve weaker, and therefore the acid in the stomach overcomes the pressure gradient and gets back up into the esophagus and causes symptoms. The easiest way to make the diagnosis is the patient thinks they're having heartburn. They see their primary care physician. They'll give them a trial of an acid blocker, Pepcid or Protonix or Prilosec, one of those type of medications. And if their symptoms get better, you know they have reflux. And if they're improved and resolved, then that's all you really need to do. If they're not resolved, or if they've had reflux for a long time, there'll be other tests that we'll want to do. The first one being an endoscopy, where the gastroenterologist or ourselves will take a lighted camera, look down the esophagus just to make sure there's no damage to the esophagus. If somebody gets severe enough where the medications aren't causing their problems, and they aren't solving their problems, and they think they want to consider something surgical, there's some other testing that we can do to quantify how well their esophagus works, how bad their reflux is, and how large their hiatal hernia is.
Gotcha. At what point should someone consider surgery over medication?
Really, 3 main considerations. One, the medications just don't work for you anymore. And over time, you'll become tolerant. You'll have to escalate your doses. A lot of that's just because the valve's getting weaker and weaker and weaker with time. Another indication for potential surgery is somebody who either does not want to take the medications because of cost, inconvenience, or they're concerned. There's a lot of stuff in the literature now about potential side effects or complications from the medication, so that scares some patients, and that's perfectly reasonable reason to consider surgery. Somewhere where sometimes the GI doctors and the surgeons disagree a little bit is when somebody has a complication from their reflux, like I talked about earlier, like a stricture, which is a scarring or narrowing of the esophagus where it doesn't empty very well, or Barrett's esophagus, which is basically a precancerous lesion, which is caused by reflux as well, would be, in my opinion, an indication to consider something more aggressive than just medications, i.e. surgery.
Gotcha.
So fundoplication and the LINX device are 2 different mechanisms we have to restore the valve for reflux. They work a little bit differently. The fundoplication, there's no foreign bodies involved. You take the stomach itself and you can wrap it anywhere from 180 degrees around the esophagus to 360 degrees around the esophagus. And we're really not trying to squeeze the esophagus. We're just trying to recreate the angle between the esophagus and the stomach. The way I describe it to patients is it essentially kind of creates like a nipple valve inside the esophagus where food can go down, but does not, and liquid and food don't come back up into the esophagus. The LINX device is actually a mechanical bracelet just wraps right around the esophagus, and it's calibrated such that the force to break these magnet seals is about 3 times stronger than what the force to cause acid to get from the stomach back up into the esophagus. Yet it's only about half as strong or a third as strong as the force the esophagus has to push food down into the stomach and so forth. So it's strong enough to stop the acid, but not strong enough to stop the food from getting into the stomach.
Why is it magnetic?
They just looked at the best way to control the forces, and magnets just seemed, because of scarring and so forth, just better suited for that.
Interesting. So what you're saying is option 1 is you wrap someone's stomach around their esophagus?
Correct. Yes.
Option 2 is this really cool magnetic gadget.
Right. In both options, we do repair the hiatal hernia. We pull the stomach back down where it's supposed to be. We close the diaphragm so the stomach does not go back up into the chest or recreate the hiatal hernia. Right.
Interesting. Who's the best candidate for each one of these procedures? Like, how do you decide which route to go?
Uh, Patient preference, typically on which procedure they want, whether it be the wrap or the LINX, magnetic sphincter. A lot of people end up choosing the wrap because in Alabama, it's not the LINX device is not covered as well as maybe in some other states. Both are equally as effective in preventing the reflux and have a very similar side effect profile. The LINX device is actually a little bit easier and a little bit, to be honest, dependent on the surgeon's technical skills as far as creating the wrap, because you just measure the esophagus. It tells you what size device to put on. You wrap it, and if you can buckle your belt, you can buckle the LINX, and it fixes it. But who needs operation, again, we talked about a little bit earlier, is basically people who need to come off their medications because either they're not working for them, they're having breakthrough reflux, or they're having complications. But both work just as well as one works just as well as the other. People who choose the wrap, either it's a financial reason or they just don't like the idea of having a foreign body implanted. People who choose the LINX want a simpler, quicker operation that may actually be a little more durable because these are rare earth metal magnets, which should last forever. The wrap, over time, 10 to 12 to 15 years, may loosen a little bit, causing some reflux, but that's what our tissues do. As we age, things tend to loosen a little bit.
What is the typical recovery process and diet transition after surgery?
Right. So it's a little bit different for each procedure. With the wrap or the fundoplication, we use your body's own tissues. Operation typically takes 45 minutes to an hour. It's typically an overnight stay in the hospital. And because of some of the swelling and so forth, we like to leave patients on liquid diet anywhere from 2 to 4 days until the liquids are going down very well. Because there's going to be a lot of swelling early on. The last thing we want is then to eat a sandwich or something, it gets stuck, and then they regurgitate or vomit and then tend to break the repair down. After about 3 or 4 days, they'll be on soft foods for about 2 weeks. I describe that to patients. Anything you can push a fork through: eggs, potatoes, peas, fish, those types of things. And at 2 weeks, we'll see them back and start advancing them. With the LINX device, we typically start those patients on solid, soft food, but solid food from day one. It's a shorter operation, takes about 30 minutes to do. A lot of those patients can go home the same day because there's less dissection. But what's going to hold the LINX device in place long term is there's going to be a scar capsule that develops around that. If you're just drinking liquids and you never open the device or activate the device, that scar capsule is going to form so tight that it won't activate. So I describe it, it's kind of like physical therapy when you go have your shoulder done. They're going to send you, it's not going to be fun. They're going to move it and kind of keep that scar tissue loosened. Your physical therapy after a LINX device is eating a soft diet. Not large portions, but something 8 to 10 times a day, every day for the first 2 to 4 weeks, so that scar capsule forms so that the device can continue to open.
What types of improvements do patients usually experience post-surgery?
So these are probably some of the happiest patients I have in my practice. We'll have patients that have the operation. Maybe their symptoms are well controlled on medication, but they have a complication like Barrett's or something like that, so they want to have the surgery. We'll do the operation, and probably 98% of my patients will come back to me and say, I just thought my reflux was controlled prior to surgery. Now that I've had the surgery, I realize I was never really controlled, and that's exactly what's going on. The medications do not stop patients from refluxing. They just change the pH so it doesn't burn as much when they do reflux. With the surgery, we recreate a valve so you don't reflux as much. I tell patients that 90% of my patients will never take a medication ever again for their reflux. And most of them are just kind of flabbergasted because they've been on escalating doses of medications with not great relief for as long as they can remember. 8% will still take a medication occasionally, but it's usually not the strong medication. It's just a Tums or maybe a Pepcid over-the-counter type of a thing. About 2% will still take something on a regular basis, but it's still a lower medication with far better reflux control than they had before surgery.
It's actually amazing results
Yes.
for someone that has this. So if I were to contact, or if someone were to contact their provider about exploring a GERD surgery, like what should someone ask?
And just be honest with your primary care doctor. A lot of times physicians just think of reflux, oh, it's a diagnosis, but it's not a real diagnosis. Like coronary artery disease or kidney disease or hypertension, whatever it is. It can be life altering for patients. But if you have severe reflux, you want to come off medications, you want to talk to somebody, just mention that to your primary, and either any gastroenterologist in the city can work that up, or we actually have all the tools we need in our office: endoscopy, motility studies to look at the esophagus. We actually can put little probes in the esophagus to just quantify exactly how severe your reflux is, and that test will also tell me how likely whatever symptom you're having is related to reflux. So I can tell you this symptom is probably may or may not be related to reflux based on how well you did with the computer, or this symptom, 99% chance it's going to go away when we fix your reflux and so forth. But yeah, just talk to your primary care physician. Tell them you at least want to have a conversation with either a gastroenterologist or a surgeon about your reflux, and let them take it from there. If you're going to consider surgery for reflux, you really probably ought to find a surgeon who either specializes in this or does more than just an operation for reflux once every now and then, because there are other diseases out there that can mimic reflux, and if you do an anti-reflux operation, you may make the patient worse. One disease is called achalasia, where the esophagus doesn't empty. To the patient, it feels very much like reflux, just with a little bit more food not going down. And if I was to do a wrap around that, it would make you worse. So we do what's called a manometry on everybody before we do any kind of wrap. It's a motor function study of the esophagus. It tells me how well the esophagus functions, how well it empties, how strong the contractions are. So can I do a full wrap or a partial wrap, etc. It also tells me where to put the pH probe, because there are studies on how close to the sphincter or to the stomach that you put the probe, so you get the right data. So you can do that somewhat visually, but you can't see the sphincter itself. I can't see it endoscopically. I can't see it surgically. I can't even see it pathologically. The only way we can know where the sphincter is using pressure studies, the manometry studies. So that study tells me where to put the probe so I get accurate data, because much as we love to do surgery, we want to do surgery on the right patient. And we don't think everybody needs surgery for reflux. And I will tell the patients every time when they come to my office, if your symptoms are well controlled with medications, you don't mind taking the medications, you don't have any complications, I'm happy to talk to you about it, but personally, I wouldn't have the surgery. If my symptoms weren't controlled, or if I was having complications, I would definitely have the surgery, because I know how effective it is, and the side effects, potential side effects of the operation are definitely worth the benefits and so forth that I'm going to receive.